Good afternoon, everybody, and thank you for joining us. I'm Brian Carpenter. I'm one of the co-directors at the WashU Center for Aging, along with my colleague Nancy Morrow-Howell, and we're pleased to have everybody here for our Issues in Aging webinar series. Before we dive into today's presentation, just a pitch for the upcoming Issues in Aging webinar series, which will feature Dr. Derek Isakowitz, who's a new faculty member, came to us from Northeastern University in the Department of Psychological and Brain Sciences, who studies emotion regulation and aging. Should be a great presentation, so hope you can make that session as well in October. But today we're super pleased and excited to have with us Dr. Todd Becker, who is a new WashU community member who came to us recently, finished his PhD at the University of Maryland in their program in social work. Before that, Dr. Becker finished his MSW at the University of Iowa and completed a bachelor's degree at the University of Iowa as well. His research interests are varied and all interesting. He's a very prolific scholar already in his current status as a postdoc in a wide range of areas in end-of-life care and palliative care, including pain management, and as you'll hear about today, medical aid in dying. So please welcome Dr. Becker. We'll be having the chat open throughout the presentation, but please hold your questions and place them in the chat till Dr. Becker's finished with his presentation. Then we'll open up the microphones and have plenty of time for Q&A. So Todd, thanks for joining us today.
Hi, everyone. Thank you so much. I'm going to just take a second and get my screen shared and lined up, and then we'll begin.
Looks good, Todd.
Perfect. Okay, so we will get moving then. Thank you so much for the generous introduction, Dr. Carpenter, and thank you everyone for being here today. I know we all have so many responsibilities pulling us in different directions these days, so I'm really grateful that you all chose to spend your lunch hour with me to learn a little bit about my primary area of research, medical aid in dying, or as I'll call it, MAID. So we have about 30 to 45 minutes today before questions, but before I begin, I'm just going to note that I have no disclosures or potential conflicts of interest in relation to this presentation. So Dr. Carpenter kind of touched on this a little bit. I am currently a postdoctoral research scholar in the School of Medicine here, specifically in the Department of Surgery and the Division of Health or Public Health Sciences. I am supported by an NCI-funded T32 training mechanism in cancer prevention and control. I came here by way of completing my PhD in social work at the University of Maryland, Baltimore. I did a 3-paper dissertation on medical aid in dying titled Attitudes for Medical Aid in Dying in a National Sample of Hospice Clinicians. The papers of which are just starting to come out. I'm very excited about that. But I think more broadly, the conversation of how did I come to this work is kind of crucial in grounding sort of my approach to it and how I think about medical aid in dying and my place as a social work researcher in the field. So my introduction to the profession of social work and the concentration of aging and the topic of medical aid in dying all came through the same mechanism. They all came through an elective that I took in my final semester of my undergraduate study at the University of Iowa. So I find this to be such a full circle moment to be speaking about it now from the vantage point of someone who's actively engaged in their own research on the matter. And I'm fortunate in that I get to keep learning about something that I've been interested in for over a decade while pursuing my own questions on the topic as well. So for many reasons that we'll touch on, medical aid in dying is a relatively niche area of practice and research. So I wanted to thank my wonderful colleagues near and far for learning with me and helping me to advance clinical care and research for those at the end of life. These particularly include Carla Washington here at WashU in the School of Medicine, as well as Stacy Fisher, Dan Matlock, and Eric Campbell at the University of Colorado. And then finally, Alyssa Kozloff at Rutgers University and Cindy Kane at the University of Alabama at Birmingham. These people are all part of ongoing planned studies that I'm conducting right now. And so I wanted to recognize them and their contributions and investments. So the purpose of my talk today is to provide a high-level overview of current issues in MAID in terms of clinical practice and how research keeps pace. Drawing from the title of the talk, I'm going to speak both to MAID as a concept and also MAID in practice. Specific objectives therein include first to introduce and conceptually define medical aid in dying, and then to articulate challenges to clinical adoption and access. And then I'll conclude by providing kind of a flavor and an introduction to my current and ongoing research that hopes to distill these practice-based challenges that we will previously flesh out. So the first objective then is to introduce and conceptually define medical aid in dying. So when we're talking about MAID in the United States, we are talking about the process through which a qualified patient self-administers a medication prescribed by an attending provider with the express intent of hastening their death. As you might infer, MAID is a highly polarized topic. Utilization is highest in patients who are college educated, white, male, and with cancer diagnoses. Notably, these kinds of distillations point to overarching questions of whether this reflects true preferences within these populations or whether it actually might reflect access barriers. Notably, others are allowed to assist in the preparation of the medication, usually a combination such as DDMA or DDMP. However, the patient alone must be the one to make the medication enter their body. The most common route is oral, whereby patients usually consume a numbing agent first, such as a popsicle, to numb their taste buds to the bitter taste of the medication, and then would mix and consume the medication in an agent such as applesauce to make it easier to go down. And then finally chase with something again in order to kind of dull the bitter taste of the medication. Complications for medical aid in dying are somewhat rare, but also not fully or systematically investigated yet, but include prolonged time to death. For instance, my own research has shown that death can take anywhere from 2 to 18 hours, nausea and vomiting, and then in extreme instances, waking back up. So following Supreme Court decision MAID in the US is legislated at the state level. The practice is currently legal via statute in 9 states and Washington, D.C. These jurisdictions collectively account for roughly about 1/5 of the US population. So if we'll look back to the definition, MAID's definition might sound similar to other terms that you've heard of. MAID can be used somewhat interchangeably with physician-assisted death, physician-assisted dying, or death with dignity, the latter of which typically connotes more so the statutes than the actual practice. But Canada and several European countries that have legalized the practice refer to it as physician-assisted suicide, which persists here in the United States too, albeit particularly among opponents of the practice. This is important because insofar as MAID semantically refers to someone ending their own life, the term suicide or the reference to suicide might be appropriate. However, I tend to side with the American Psychological Association, the American Suicidological Association, and the American Public Health Association, who have all kind of roundly contended that MAID is categorically different from suicide. Some of this stance for me comes from the very specific socialized and stigmatized meanings that society has come to attribute to suicide. We can think of kind of persisting legal, even kind of time capsule-like language, such as the term to commit suicide in reference to this. But the bulk for me, I would say, comes from empirical differences in descriptions and experiences by each population that kind of draws out differences between these modes of death. By clinical and legal definition, MAID requires that patients have a prognosis of 6 months or fewer to live. Therefore, unlike the context of suicide, the proximity of death in MAID is not so much a question of if, but really of when and how. This distinction is important because it's led to reports that those who pursue MAID would not otherwise move to hasten their death if they were not already dying. A final term that's important to kind of contextualize the understanding I've made is medical euthanasia, which describes a parallel process that culminates in a physician's administration of the medication, not the patient's. This distinction is really important because it supersedes semantics. So by that, I mean that first, unlike MAID, euthanasia is illegal everywhere in the United States. It is not legal anywhere in the country for a clinician to intentionally hasten the death of their patient in this way. Law and clinical care draw a very strong distinction between administering means that will hasten a patient's death and also withdrawing means that will withdrawing means that intend to prolong life. Such as, for example, we can think of compassionate extubations. That is legal everywhere because you're withdrawing a means that prolongs life and allows natural death to occur, as opposed to actively administering something to hasten death or bring it about sooner. Second, this distinction is important because when expressing preferences between practices, patient groups and provider groups differ. So by that, I mean that patients, by and large, tend to prefer euthanasia, which is illegal everywhere, while provider groups tend to prefer euthanasia, which is, or medical aid in dying, which is illegal in these select states. What this to me connotes is that there's something really formative ongoing or going on with the act of administering the medication between these really important players in the process. So from the outset, it's important to note that there's a documented history of MAID functioning as intended with no evidence of widespread abuse. For this, many of the states that legalized MAID largely followed Oregon's model. Oregon was the first state to legalize first in 1994, and then it was contested and it was re-legalized in 1997. So most of the subsequent states that we saw from the previous figure to have passed MAID have largely followed the Oregon model, albeit with subtle tweaks. Nevertheless, generally, the eligibility and qualification criteria are consistent with Oregon's original stipulations. Eligibility criteria, by and large, dictate that patients have an age of at least 18 years old, that they are residents of the state in which they're pursuing MAID, that they have been verified in the mental capacity to make this medical decision, and that they have the physical ability to self-administer the medication, and finally, that they have a diagnosis with a terminal illness of 6 months or fewer as a prognosis. Then the qualification criteria. So after you've been eligible, what are the steps you have to go through? Qualification criteria then hold that patients must have their mental capacity verified by an attending and a consulting provider in instances when the conclusion is not agreed upon or otherwise elusive. Those providers must then refer out to a third party, usually a psychologist or a social worker, for a further formal consultation. Patients also have to formally submit 2 oral requests and 1 written request, each separated by mandatory waiting periods. These waiting periods vary from state to state, with a lower bound of 48 hours and an upper bound of 17 days. So why does this definitional clarity matter so much? First, it matters because MAID utilization rates are rising even within jurisdictions, permissive jurisdictions. They're rising in really interesting ways too. So looking at Oregon as the state with the most experience, we'll see these interesting trends illuminated. Through the purple line, we see increases in rates of death via MAID. We also see a growing chasm between prescription receipt in the green line and then what we can infer to be prescription utilization, the purple line. What many scholars have taken from this and what I've taken from this and what research routinely backs up is that the relief that MAID offers patients and families is not tied exclusively to death resulting from medication ingestion. Instead, awareness of the mere availability of MAID as an option has been recognized for improving physical symptoms and for offering a psychological benefit to patients through the restoration of their senses of control. My own research has borne this out. I completed an interview recently with someone with leiomyosarcoma, a cancer with an annual incidence of about 1 in 100,000 people, just last week, and who qualified for MAID. And she said, immediately after getting cleared for MAID, I felt like I could breathe. It was a huge weight off my shoulders that I wouldn't have to suffer and die like that. This recognition has led other scholars to contend that the mere availability of MAID itself can function kind of palliatively in nature. This trend might be related to then the second trend that I'm going to highlight, and that is that MAID legalization is projected to expand. MAID legalization proliferated in recent history. Looking at the graphic, 7 of the 9 legalizing jurisdictions passed their policy in the last 10 years. That's huge. I attribute this to the largely sociological concept of structural lag, referring to society's delay in modernizing its social structures to keep pace with citizens' evolving ideals and values. Of note, the first bill submitted to legalize MAID was submitted in 1906, almost 100 years before Oregon's pioneering legalization in 1997. The concept of medical aid in dying in the US is not at all new. To that end, Gallup poll data have shown majority support by the American public since 1996. The current estimate is about 61%, and it's tended to vacillate between like 50 and 70 ever since that time. The recent boon then in this legalization suggests that continued expansion is to be expected. For instance, New York and Pennsylvania are roundly considered to be battleground states. They've entertained MAID legislation multiple times in the past and are largely seen as considerations of when this will happen, not really if it will or if it won't. We also see grassroots pushes from all over the country. So for instance, our shared home state of Missouri recently introduced a bill this past year. These pushes also come from states that are highly conservative, at least in their legislatures. So for instance, Florida introduced a bill in 2023 as well. And the complement to this push toward legalization is that to date, there has never been a successful repeal of any MAID statute. It's just not happened, signaling that MAID is here, and frankly, it's here to stay. And so as a result, we know that more patients are going to be inquiring about MAID, both within and beyond currently legalizing environments, therefore introducing a really weighty implication for clinical practice. So then we'll move into objective 2 to describe the challenges to ethical adoption and access of medical aid in dying. So I find it helpful when thinking about bioethical debates to kind of hone in on what the common pro and con arguments are. And I'm going to say from the outset that I'm very much painting with a broad brush here for the sake of time. But commonly ascribed pros are that MAID represents someone's bodily autonomy and therefore is an extension of a patient's ability to self-determine what they want for their own life and their own well-being. Commonly ascribed cons then are that MAID is not the place of medicine and that it contravenes interpretations of leading medical ethics. For instance, we might think of the Hippocratic Oath or the push to do no harm. My own interpretation is that both sides of the aisle, at least in regard to these arguments, come up really short in relation to resolving disputes about MAID, with the reason why kind of being baked into the definition itself. So let's take care of the cons first. Arguments that MAID is not the place of medicine fall short when statutes effectively invoke the institution of medicine in order to constitute MAID. This contention and the contention of the Hippocratic Oath are offset by the observation that healthcare professionals can and have participated, suggesting that MAID can, rather than does or does not, have a home in medicine, and that MAID can, again, rather than does or does not, accord with the Hippocratic Oath. In terms of pros, bodily autonomy and self-determination both rest on premises that don't fully align with the statute as written. The statute, by definition, requires the participation of healthcare professionals. So autonomy and self-determination were never truly within the full control of the patient in the first place, giving rise to some really interesting trends and dynamics among the key players and how they all have to work together to furnish or not access to this option. In this way, bioethical scholar Anita Hanig has characterized MAID as what's called agentively displacing, because the patient's ability to exercise agency in pursuing MAID is facilitated or obstructed by a clinician's agency in determining whether or not they will participate. So working then from this framework of agentive displacement brings what appears to be, to me, the kind of gravamen of MAID into sharper focus. For instance, I don't think that the adage that MAID is about a patient's right to end their own life is fully accurate or representative of the issue at hand. Uh, Speaking to that, suicide has been largely decriminalized in the United States since the 70s. The same with assisting in suicide, at least in the traditional sense. Um, the aforementioned points then clarify a more specific tension around not whether patients have this right, but what is the role of medicine in facilitating this process? This distinction is really important because this debate is far from settled. We see a viewpoint published in JAMA just this past week, actually, one of the very first MAID focused articles there, and considering this very topic and kind of wrestling with like, how does this integrate and how does it integrate, and also what are the parameters? This distinction is really important because agentive displacement is codified into law through each of these statutes through conscientious objection. So what is that? Conscientious objection is essentially the legal protection for healthcare entities to object to any and all participation in MAID. Healthcare entities include individuals and facilities, so entire health systems can opt out of providing MAID. Any and all truly means any and all. This can include serving as an attending provider, serving as a consulting provider, assisting in the coordination or provision of MAID-related care. It can even include referral if you are conscientiously objecting. By law, providers must refer patients only once patients themselves have already identified a replacement provider. Though in practice, this is likely rare, and I would like to think that providers who are conscientiously objecting forward clinical documentation in a timely manner. Conscientious objection is fundamentally designed to account for and respect differences in opinion. That's the express intent of doing it. There are very reasonable rationales for why people would not want to participate in something like MAID. Most commonly, these reasons are about intimate and personal values, both religious and not. And my wonderful physician mentors have said, and I completely agree, that they would sincerely worry about anyone who doesn't really grapple with this and second guess whether they're doing the right thing by doing this, just because of the gravity of the situation and what it can mean in a reverberating sense. There are also issues concerning agency solvency. For instance, roughly 70% of hospices are now for-profit entities, so taking on a politicized stance could reasonably threaten their ability to stay open and provide needed care to other patients. So what happens then with conscientious objection is essentially this. It inadvertently creates kind of a multi-level precarity in patient access to MAID, whereby patients must live in a state first that offers MAID and must be affiliated or receive their care at a facility or healthcare system that conscientiously participates in MAID. And because of this well-established interdisciplinary needs arising throughout MAID and throughout the whole process, patients must also receive their care through a team of clinicians, each of whom will be, by virtue of participating, conscientious participants in the process. So let's talk about then how conscientious objection manifests in clinical practice across these levels. In terms of facilities, it manifests kind of in obscurity. That is, there's a lack of public-facing messaging insofar as health facility or health system positions. This is especially notable in California, where the End-of-Life Option Act requires public health care institutions to publish their position statements. Doing so is considered important so that participants wouldn't enroll in, for instance, a hospice, only to find out that the entire organization had already opted out of MAID if they desired, and then to find themselves in a really precarious situation of needing to enroll in a different hospice and coordinating all of that care. A recent study, though, published by one of my mentors, Cindy Kane, found that roughly only about 1/3 of California hospitals actually published their organizational position statements, a finding which the team attributed largely to a lack of oversight or reinforcement mechanisms. So we're seeing a patient's inability to make an informed decision about where they're getting their care in the first place. So then moving to clinicians, when facilities do participate, there are several resounding implications for clinicians. For instance, we know from decades of psychological research that decision-making is not clear-cut. Clinicians have reported wrestling with both objection and participation, even when they stand by what they did and think that it was still the correct decision. Research has shown that clinicians, even when referring out in a timely manner, have felt as though they've abandoned their patient, for instance. Likewise, research has also shown that those who have participated in the name of patient-centeredness against their own misgivings have experienced extreme and prolonged distress. Such discomfort has left some nurses to leave hospice care altogether because they didn't want to have to continue to confront it. Individual decision making is also exacerbated by the highly variable parameters set forth by participating agencies. These policies are often born out of a desire to avoid speculation of patient coercion and otherwise being the one to make the medication enter a patient's body. So if patients are really decompensated, they're in significant clinical decline, and they cannot be the one to administer the med, then you might be faced with a request to help them do that, which would contravene the law. These policies tend to condition very highly regimented and likely impractical scenarios in which patients may participate, kind of, but with understandings of where those lines begin and end. These are often called leave the room policies in states that have made where clinicians would need to leave the room during the time in which a patient is administering the med so that they're not kind of on the hook for coercion or any kind of speculation thereof. But the issue with that is that we know that situations can and do go awry in end-of-life care. This is exactly what happened with a colleague of mine. Her hospice policy was that you couldn't be in the room when a patient was self-administering the medication. She followed that rule, but she was called back into the room when patient was experiencing a complication and vomiting the medicine. She administered an antiemetic, and because she entered the room to do so, she was fired from her job for breaking facility protocol. For her, the insult to injury then was that the hospice now sends her all of their MAID referrals to deal with on her own as a contract employee. Finally, we see a lack of training. This is actually the number one thing that I see in published research. Clinicians simply don't know how to provide this care well, and they don't know even where to look for training. We researchers will understand the weight of the sentiment when one clinician research participant from Canada said that participating in MAID essentially was saying that we are living grounded theory. Building up an evidence base for clinician training and education, at least here in the US, is really an uphill battle too, because like conscientious objection, the block on education and training is codified into law. The Assisted Suicide Funding Restriction Act of 1997, passed in response to Oregon's adoption of medical aid in dying, prohibits the use of federal dollars for anything related to the provision of MAID. Doing so means that research grants, such as NIH grants and ostensibly parts of educational curricula, cannot be used to address the needs that clinicians reference most. As a result, to date, the American Clinicians Academy on Medical Aid in Dying appears to be one of the foremost founts of training and education, both for patients and families, and clinicians have reported using it. But a struggle is how do we get the word out there even? And so it's the same access area of how do we put information in front of people. Finally, for patients, the implications of conscientious objection are largely in the identification of facilities and clinicians willing to take on this aspect of care. This means that individuals working through an already arduous process at the end of their lives may need to seek out and secure another provider to take over their care, which could further exacerbate the timeliness of moving through the MAID process. This kind of gives rise to a really concerning problem because we're looking at, as a rough analog, hospice care, where median enrollment is 15 days. So if you are enrolled in hospice pursuing MAID and trying to find someone who will take over this care for you and you can't, this introduces other time constraints in an already fraught process that could really exacerbate one's access to MAID. I think of this in relation to that same participant I was just talking about, the one with leiomyosarcoma, who approached and was denied from three separate physicians, oncologist for PCP and a third physician. None of these providers offered to refer her to anyone else. None of them offered to help her find someone else to take over her care. And when I asked what her plan was, she said she was just going to wait for the weekend and then get out the yellow pages and run the list of potential physicians and give people calls. Uh, so when asked what one thing is that would have helped her in this scenario, she responded the construction of a provider registry, kind of seemingly without knowing that doing so is illegal to protect the identities of participating clinicians. So why does this issue exist of conscientious objection and how it manifests? Why is this still an issue? It's an issue because MAID itself is a polarized issue. Even when passed, there's not really the fanfare that accompanies other policies because MAID is so ethically contended. This polarization kind of plays out in an intermediate level between state legalization and facility and clinician adoption. And that, in my view, is the level of institutional positions. So as shown by the article to the right, the vast majority of medical and surgical professional societies in the US do not publish position statements on MAID. If they do, they are by and large stances of opposition, followed by study neutrality. So study neutrality was a novel approach introduced around the time that MAID was relegated to the state courts that describes the ability for professional societies to remain intellectually engaged and curious while not stipulating an official position on the matter. Part and parcel with these approaches is that they allow for individual clinicians to decide for themselves the scope of their lawful participation in MAID. They have, although these positions allow for continued clinical and scientific curiosity, they don't help individual clinicians to consider how these decisions should be made or ultimately what goes into making these decisions and providing MAID in the first place. They've therefore received criticism for offering suboptimal guidance and support to frontline clinicians by ignoring the reality of MAID's presence, increasing presence actually, in the clinical encounter. So scholars have then taken this and contended that not dictating a stance toward MAID shifts the responsibility really onto individual clinicians just de facto to navigate these situations independently and without guidance on procedures or best practices, which as we've noticed before, can kind of culminate in feelings of distress and feelings of isolation. The implications of this today is kind of a chilling effect in which individual clinicians don't know where to look, and they also might be scared to voice their desires for more education and training. So we're going to transition now into objective 3 to introduce my current and ongoing research to distill some of these practice level or practice-based challenges. And I'll do so by introducing very briefly, I hope, one of my dissertation studies and then one project that I'm currently engaged in on an ongoing basis. The first one was a primarily qualitative study that I conducted for my dissertation. And this study recruited a national sample of 413 interdisciplinary hospice clinicians representing the Medicare hospice benefit defined interdisciplinary group. So by that, I mean physicians, nurses, social workers, and chaplains. Participants completed a one-time multi-method Qualtrics survey. And for this particular study, I made use of two items. The first one was a quantitative item that asked, would you be willing to be in the room with a hospice patient using medical aid in dying from the time they administer a lethal medication until after they die? I had response options for yes, no, and unsure. And then I summarized responses to this item via descriptive statistics and kind of used these results to inform quantitative subsamples of willing, unwilling, and unsure, respectively. Results from this first item indicated that roughly 3/4 of participants voiced that they would be willing to be present throughout MAID, and that the remaining quarter was split between unwillingness or unsureness. So I also included then a qualitative item asking participants to please explain the rationale behind their response using a character unrestricted text entry box. These open-ended responses were content analyzed using Erlinson and Brycevich's four-step method. And results of this analysis then led to the formulation of several categories. So for instance, under willingness, we had personal support, perceptions of quality clinical care, professional values, boundary setting. For unwillingness, we had professional objections to MAID as a concept, professional objections to participation in MAID, and misalignment with healthcare. And then finally, for unsure, we had ambivalence and a lack of experience. So I'll touch on these findings very briefly. Um, Personal support, the very first category under willingness, was essentially a category saying that they would support being present in MAID because they support MAID as a concept. This personal support was largely derived from personal stances. Usually, I saw a lot of mentions of human rights in here, the right to die, and so it was tied to broader ethics and broader values of conditioning how participants live. One physician, for instance, said, I think MAID should be a right for all dying and terminally ill people, and that they should be able to have support from their care team. The next was perceptions of being present throughout MAID as reflecting quality clinical care. A lot of this was tied up in the need to better understand the determinants of complications to be able to then subsequently provide better care to future patients. And so one physician kind of honed in on this and said, medical aid in dying is a relatively new procedure for which the complication rate is unknown. Having a skilled clinician at the bedside optimizes the chance of the patient getting the death that they desire. Then professional values. Typically, as we noted, medical ethics have been invoked when combating or using stances of opposition toward MAID, but we actually saw the opposite here, that people did see ways in which medical ethics supported the decision to be present in MAID and to facilitate access. One nurse, for instance, said the patient is in charge of their own life and death and should be throughout the hospice experience. And then the final one is boundary setting, which was a really interesting one for me to think about. And it was definitely, even by virtue of their quantitative response, erring on the side of support. And yes, I would be there, but I would do so in these select scenarios. And so what we saw then was some of what we talked about a little bit earlier of, yes, the facility would allow it, but I have my own individual criteria that patient cases would need to meet for me to be able to consider doing this. And so one physician said, if no family member were present at the bedside, then I'd be willing to stay with the patient. The availability of family to be present was roundly seen. Other things that came into play is if they were in hospice, if they've done all interdisciplinary workup, so other third variable conditions. Those who are unwilling, for instance, they first premised their decisions on personal objections to the concept of MAID. So this is kind of similar to the one that we just saw of personal support. It was just kind of a wholesale rejection of MAID as a thing. The perception was we should not be doing this at all. One physician said no person, regardless of their medical condition, has the right to take their own life. A little bit different, but and distinct. A distinction that I appreciated was a second group of participants who had objections not to the concept of MAID, but only to their participation therein. One chaplain actually went forth and said that this would exacerbate, that their participation would exacerbate public misconceptions that are already prevailing about medical or about hospice care, namely that hospice is already perceived in killing people. These other personal objections were really built around the meaning of support, and such that being present would imply support for the action of medical aid in dying. And then I just talked about this one, perceptions of MAID's misalignment with healthcare, being that hospice is already perceived as killing people, and that further engagement would only amp up this perception in the eyes of the public. Finally, we saw the group of those who were unsure. The first category that I created here was about ambivalence. And so push and pull factors and being pulled in two different directions and not really knowing where to land. And the fact that these push and pull factors precluded their ability to really decide one way or the other. One social worker said, I do not believe that healthcare providers should participate in or support MAID. At the same time, I support my patients regardless of whether I follow their same beliefs or principles. The final one, which was one of my most interesting things that I saw and actually played a part in one of my other papers, was a lack of experience, and specifically a lack of experience tied to legalization of where they lived. Um, in many instances, not being within an environment where medical aid and dying is a manifest reality led to ultimately not having thought through all the steps that would go into it. And so one physician from a state where it's illegal said, I have not given much thought to this aspect of MAID, mostly because the above conditions aren't true for me. Clearly, I have some thinking to do about this issue. The takeaways from the study to me were ultimately that there was strain and struggle reflected in every quantitative subsample. That this was not a clear-cut decision to be made. And there were a lot of factors that ultimately conditioned where someone kind of entered into the debate. Ironically, I thought I was doing something well by not dichotomizing into just yes and no. There's a lot of gray area here. And apparently, even within yeses and even within nos and even within the unshores, there was still gray area that they. So, what I take from that is participants selected the one that most applied to them, but still had some kind of like, maybe not misgivings, but still had certain conditions that they didn't feel were adequately represented by such broad buckets of yes, no, and unsure. Second, MAID is about much more than a discrete event. I saw opportunities for family support before the fact, opportunities for bereavement support after the fact. I saw about social workers talking about planning and choreographing the event, making it really stand out to me that medical aid in dying should not be viewed as just the ingestion. It really needs to be viewed as a process. And then finally, tensions with repeating the status quo of unpreparedness. Even people who are unsure didn't want to have to keep being put in this position of not knowing what to say and not knowing who to refer to and how to refer and all of the processes that go into that. The people who were willing because they didn't want to keep feeling as though they didn't know what to do for their patients. As an aside, I'm very excited to report that this paper was just accepted in palliative care and social practice. And so it'll actually be out there soon in print. And then looking forward to my ongoing work. My ongoing work is related to understanding key stakeholder perspectives, so that being patients, families, and clinicians. I'm lucky enough to be engaged in a rigorous and multi-site R01 on MAID. This is the very first R01 on MAID to be funded by some of my wonderful mentors at the University of Colorado. The study has three specific aims. One, to understand quantitative and qualitative outcomes of seriously ill older and younger persons pursuing MAID and the patient level factors that are associated with subsequently using MAID. Two, to understand the quantitative and qualitative outcomes of caregivers of older and younger patients pursuing MAID. And then three, to quantitatively examine the attitudes and experiences of clinicians prescribing and caring for patients considering MAID. Within these three aims, we are recruiting healthcare professionals, patients, and family members with the overarching goal to understand how each of these stakeholder groups moves through the process of MAID access and, if applicable, MAID provision. We've begun presenting preliminary data via several conference presentations and have begun qualitative analysis of some of these aims. And so we're excited to keep pushing that forward. Unsurprisingly, recruitment's been really challenging, but a rewarding experience to think through. And I'm looking forward to learning some of the great lessons on the horizon. So with that said, I will thank you so much for your time and would love any questions that you might have.
Thank you so much, Todd, for the great presentation. And the chat is open. We encourage people to use the chat. We're also going to put everybody back on the screen. So you're welcome to unmute yourself, raise your hand, ask your question that way as well.
So I see one question. is there a correlation between increased MAID utilization and increasing cost of healthcare? Is increased attributable in part to increased awareness of the option? This is this is a great question. This is a really tricky question to answer. And it's tricky in part because of the Assisted Suicide Funding Restriction Act. So no federal dollars can be used. Everything is patient pay 100%. And so medication runs typically around $3,500 in the few states that publish that kind of data. And so in my own research, I was really hung up on this as part of my dissertation. And I reached out to an expert in the field and said, how can hospice even be doing that? Like if hospices are paid for by governmental dollars, then how can you use that money to cover salaries related to the people who are there and doing time with patients and teaching them how to use MAID? How is it legal? And the question is still elusive to me, but it seems not to really erupt, at least in terms of salary. But in terms of expenditures, personal expenditures, there aren't the data yet to say that because it's all patient pay.
Todd, if I might take a slightly different angle on Vivia's question, my interpretation of part of her question was, do people pursue MAID more often if they find themselves in situations where their healthcare is going to be very expensive? In other words, do you decide to end your life because you're worried about the financial burden on yourself or your family? And maybe that's different than what they intended. But I was wondering if
I
you
am
could
so
ask that.
sorry. Thank you. There are no data. There are no data to say. I think like to that, I would reference like Ezekiel Emanuel's kind of landmark paper in about, I think it was 2016, where he dispels that there is any widespread abuse of medical aid in dying, and I think that they're functioning as intended. And the part of that's important is that they are intended to kind of work with patients' rationales that are medically based or kind of based in their personhood, their sense of self, and their well-being, not really financial aspects. But in terms of any conclusive evidence, no, I've not seen any.
Okay, thank you.
Thank
Joe,
you so much. I'm sorry again for
no,
misunderstanding.
I may have misinterpreted it myself. So yeah, I'm going to ask Joan if she can ask her question. Thanks, Joan.
I know, Todd, you said that the patient has to have the ability to self-administer the medication.
Yes.
Does the medication come in powder form and has to be
Yes.
mixed? So
that's a great. Oh,
right.
I'm so sorry. Please.
No, I was going to say who's responsible or who can mix it for the patient?
Yes. Yeah. So to back up, there are three different routes. Oral is by far the most common, and it's usually done in a compounding pharmacy and comes as pills. Patient and family need to break it up, pound it down into a powder, and then it goes into the applesauce. Typically, anyone can do that because that is not making the medication enter your body. The mixing is not. So patients have to cup in hand, cup to mouth. And some of why that gets really hairy, like patients have to practice. Patients do practice where they get kind of like other powders that are maybe like fiber supplements or something like that. And they have to practice eating the applesauce really quickly before it congeals. And so, but the main thing is that patients and family, whoever can assist in the mixing and the preparation, but the patient has to be the one to make it enter their body. So it's more involved when it's the oral route, but and that's where it comes down to statutes. So some statutes say ingest, which naturally connotes like this kind of an oral route. Others say self-administer, which legal interpretation goes wider. And so you see IV routes, rectal routes, things like that. But in terms of who can assist, anyone who needs to be the one to put the cup to the mouth, the patient.
Okay. And then one other comment I want to make. You were talking about the nurses, doctors, social workers, chaplains. There are, in the states where it's legal, there are end-of-life doulas that work with patients. Okay.
Yes.
Okay. And I am an end-of-life doula here in St. Louis, and I have had inquiries from people that live here on this topic.
That is one of the most important things to me. Also, yes, I attended your dual session, so it's great to see you. But that's one of the most important session or points to make to me, is that the lack of it being illegal doesn't mean that it, first of all, it doesn't mean that it doesn't happen, but also doesn't stop the requests from patients. And so I think from an educational standpoint, it kind of whether your state does it or not is almost immaterial to patient care. What's because you still know how to respond. You still have to know, right, like what to say. And so that's where some of my rub with like the lack of opportunity for training and education is like I just think it's a disservice.
Todd, I'm going to throw a couple of questions at you that are connected to this topic from James, who asked about the regimen for the medications and how they've been determined. And then a follow-up question to that is, if a patient is unable to swallow, then they are no longer able to participate.
So I'll answer the first one first. The medication. So first of all, it started with secobarbital and pentobarbital being the primary meds. I am by no means a pharmacist, but I understand that some of these high-level barbiturates have become harder to access, and so frankly, it's there isn't really a set like the recommendation for the medication is put forth by that American Clinicians Academy on medical aid in dying. Like there isn't, and they put forth the best practice of what's most readily available because it keeps kind of changing and filtering through availability things. And so it's kind of one of those things where the science isn't conclusive, but people are doing what they can and trying to get out what they know works. Um, and the second question, I'm sorry.
So if a patient is unable to swallow, does that mean they're ineligible to participate?
No, it doesn't. There are other routes like the intravenous route or the rectal route. It certainly makes it more expensive. Those routes are more expensive. But the other thing I think that you're touching on that's really important is kind of access barriers by condition. So we think of like the eligibility criteria for MAID, for instance, if you have ALS, then and you cannot put medical aid in dying in your advance directive. So if you have ALS and can't move, it's going to make it like if you can't move your arm to push a button or you can't bring the cup to your mouth, if you have Alzheimer's and you are determined not to have dementation consistent with the ability to make a medical decision at that level, then it would effectively rule you out. And so there's some really interesting dialogues happening in the literature right now. But the short answer is that it would make it harder for you to use, but not impossible.
Allison also mentioned the complication around Alzheimer's, and in her
Yeah.
experience, they're interested in it but unavailable. And Kate
Yes.
also asked a question about her experience in assisted living facilities that people are interested in this option. What do you tell people in the state of Missouri about options?
Yeah, it's it's just I kind of remember talking to my dissertation chair about this. I did all of my clinical practice in Iowa, for instance. I was in usually med surg. I just didn't confront this from my patient population. I didn't confront such explicit requests. Um, and there's a wealth of literature attesting to the fact that kind of comments about not wanting to do this anymore or something like that, that there's a very bright line between that and actively wanting to pursue something like MAID. So I did not confront this in practice. My dissertation chair, essentially, though, when he practiced in hospice in Virginia, said that he roundly received active requests and that it's some policies will, or some hospices rather, will have internal policies that'll kind of script a response. Many of them don't. And so in terms of what typically you see from these organizations where, or these states or organizations that don't participate, will kind of be some thinking around and questions with the patient asking, well, what's making you feel this way? What do we, what does it feel like? How can we onboard other supportive services? Would you be interested in these other supportive services? And it's just from the intent of trying to max out the support that that patient has.
Okay, we have time for one more question. Christy, over to you.
Thank you, Dr. Becker. It was wonderful, informative, inspiring, somewhat terrifying.
Yeah.
So my question was, I kind of have two, and you can pick which one you want to answer. So I'm wondering about kind of the pharmacy's take on this, if they know that they are filling a prescription specifically for this use. I know then this is a very different situation, but I know that like for the death penalty, for example, pharmacies refuse to fill those prescriptions because they know that it'll be used for the death penalty and they're not willing to participate in that. So I didn't know if you knew, if anything, if there was any kind of research on the pharmacies, if you want to answer that one. Or option B, has there been any follow-up with patients who have had those prescriptions filled and then chosen not to engage in MAID or do or use that method?
The answer to both questions is yes. Pharmacies can and do opt out of that, and that's their conscientious right. They do. It exacerbates challenges in more rural areas where there maybe aren't so many other pharmacies to get meds filled, but they do. They absolutely know that the strength that the medication being filled and the strength and everything would reasonably result in death. Yeah. And then the other one, yes, I forget that your question, but yes, the answer is yes.
Thanks for the questions, everyone. And thanks again, Todd, for this great presentation. Todd's contact information is easily accessible on the WashU website if you're interested in getting in touch with him with any follow-up questions. And Natalie, do you want to throw back up the slide for our final event? Next event, rather. Again, this is our next Issues in Aging that's coming up in October. So we'll leave that up there for a second in case you want to jot down the date or scan the QR code to register. And of course, the Issues in Aging webinar series is just one of the many programs and activities going on at the Center for Aging at WashU. If you're not already on the newsletter list, please feel free to join us. And Natalie has another slide that shows several different ways where you can get in touch with the center and keep abreast of everything that's happening. Thanks again, Todd. We really appreciate you sharing your expertise with us. Good luck with the research moving forward. We're looking to hearing more about it and reading more about it. And thanks everybody for attending today.
Thank you so much.
Thanks, Todd. That was wonderful. Thank you.